concussion itself, as you have heard in the news in the past months, is becoming an issue. The Heads Up program and many other programs, especially championed and spearheaded by the NFL, is to reduce the impact. However, impact is reduced but not completely resolved in many people, which I'm going to discuss when it comes to protracted symptoms. Let's give an example. The incidence of head injury in alpine sports, for instance, has reduced, but concussion is still the most common. After helmet was introduced, the abrasion, the direct injury to the scalp was reduced, but that has not affected the main injuries to the head that could either be mild traumatic, moderate traumatic, or severe traumatic injury. Today we're focused on mild traumatic injury in all aspects of engagement in sports or in issues that could lead to concussion. So, based on evidence-based reports, we know that concussion in itself will produce symptoms that would resolve in about a week or maximum 3 weeks. However, there are people that live with symptoms past that frame of time. We have some common symptoms of concussion like headache, dizziness, cognitive deficit in terms of memory issues, as well as emotional problems. But in order to understand why people do not get better, we need to understand the anatomy of concussion. How do you even see concussion? Imagine a ball, a soft ball, being put in a jar of water and covered and shaken. When you vortex it, you feel a lot of trauma to the hair on that soft ball. This could represent the type of macro fracture to the capillaries of the brain structure itself when the brain is shaken in a coup-contre-coup injury or direct impact or indirect impact to the brain via high impact explosive waves. So what begins to happen is reorganization that experts have come to call negative neuroplasticity. And sometimes it takes a while for the brain to reset. And these are the reasons for these protracted symptoms in many instances. We have patients that have been discarded by the neurologist as having no problem because the MRI is okay, the basic testing, all nerve testing, neurological testing have been found to be favorable to the patient. But the patient still complains of these symptoms. So how do we handle this particular type of patient population? How do we get them to regain their quality of life? How do we return them back to play and also their executive function activities without having to deny them of what they truly love to do? I want to propose a framework of treatment, and while I propose the framework, I want you also to understand why. The framework of this treatment should be based on neuroplasticity. There is empirical evidence that positive neuroplasticity is the best way to treat protracted symptom of concussion. But you have to go through different pathways. First of all, let's talk about the vestibulospinal pathway. Vestibulospinal pathway is affected in concussion, but based on what we know per literature, it resolves by itself. It resolves on its own spontaneously within 5 to 7 days without treatment. We also have issues with vestibulo-ocular pathway, which sometimes may take time to recover. Therefore, it's needed that a team be gathered to evaluate the patients that do not get better and also act fast on each of these pathways. The next pathway is the cognitive pathway. Some people begin to complain of memory issues that affect their quality of life, their job functions, and also ability to even make some basic executive decision on the field of play. We also have issues with emotion. In concussion, there is a cascade. For instance, starting with the eyes, when the muscles of the eyes are weak, it affects saccades, it affects convergence. What is saccade? Saccade is like when you flash torchlight, and the light is supposed to be straight light, so you move it, boom, boom, boom. It's fast. It tracks very fast, smoothly, but it's no longer smooth. The pursuit of an object is no longer smooth in some post-concussion patients because the eye muscles are weak and everything begins to shake. If things are shaking like that, it affects the ability of the brain to interpret or even calm down. It could lead to headache. It could lead to cognitive issues because things that you easily grab, you no longer grab it visually. And also it could affect emotion. When the way you see things change, it can affect your emotion. So this is the reason why at times in concussion, we might need some intervention from the mental health perspective. Again, I'm not talking of PTSD issues. I'm talking of basic techniques, basic treatment in order to restore emotional confidence, in order to correct what has been taken away by the impact of concussion. So here is my proposition for the team. A physical therapist to quickly assess and treat as needed for the vestibulospinal and vestibulo-ocular pathway. An occupational therapy to assess eye muscle movement, eye muscle strength, propose treatment immediately. If there's a problem with the physical therapist, either a musculoskeletal injury, a pain problem, musculoskeletal pain problem is impeding treatment, the sports medicine physician will play the central role of treating this patient immediately. If there's more advanced problem during treatment with using basic therapeutic intervention in physical therapy with the vestibulo-ocular pathway, we could begin to think of other things. For instance, further evaluation of the patient that may have dehiscence, for instance, may lead us to order a CAT scan of the temporal bones, and if there's positive evidence of dehiscence, the patient will now be referred to ENT for further treatment. So the sports medicine physician will play the central role surrounded by these experts. The same goes for the occupational therapist. If it is discovered that there is significant convergence issue, for instance, if a patient is not able to look straight all the time, if the patient's head cannot even focus, the patient has to turn the body, and yet there's no significant neck issue, this is a high suspicion for a major sight problem. The patient may be evaluated by an optometrist or an ophthalmologist. And sometimes in some cases we do pick who needs to see a neuro-ophthalmology, which is more advanced and will be determined on a case-by-case basis. The third person in the group is the speech and language pathologist. This will focus on cognitive deficits, because in many instances you may not be able to determine what the deficits are just by doing a mini mental score. This is why patients get discarded by the neurologist as being okay, because mini mental, they pass it easily. So a speech and language pathologist can also offer some basic treatments such as techniques to compensate for whatever is lost. And the last one is just a mental health person, but not so specifically as someone that will provide mental health services. No, we want people that we suggest therapy and also issue therapies like mindfulness-based stress reduction, MBSR. This has been shown by empirical evidence to reduce stress, especially control of racing in thought process. It is called slowing down internal dialogue. In many cases, people that have racing internal dialogue cannot think fast, so that decreases the amount of memory that is retained, because there's so much convolution in their hippocampus. They have so much going on at the same time, so any new information coming in is competing with old information that they cannot discard. So we have a bunch of therapies in that regard as well. And when you have this team, i.e. the physical therapist, occupational therapist, speech and language pathologist, and a mental health coordinator to offer therapies, we can quickly assess basic losses that could be corrected right there. If a patient has overlapping symptoms consistent with PTSD, i.e. in high impact injuries such as military related injuries, a psychiatrist could be consulted. The entire concussion recovery process could be put on hold until the patient's mental health symptoms are truly resolved. Meanwhile, with this team, I believe that we can achieve more for our young men and women in sports. Let's now talk about what can be done to this protracted headache. One very important way to approach protracted headache is to take care of the acute pain right there and there. We have had some success with some of the following interventions. One, blocking the sphenopalatine ganglion. What do we know about the sphenopalatine ganglion? It is located at the junction of the sphenoid and the hard palate. And what happens here is that a ganglion, the cell body of nerves, is located there, and what that controls is it causes vasoconstriction. So blocking the nerve will cause vasodilation, enhance blood flow in the area around the intracranial structures, and it has been known to relieve headache. It is shown to relieve headache. I'm talking of randomized control trial. Now, what's also important about this sphenopalatine ganglion is that we have nerves that run through that same way. For instance, we have the lacrimal nerve running over the area. We have this trigeminal nerve, which means that trigeminal neuralgia can be sensitive to the same block. We have the vestibulocochlear nerve, cranial nerve 8 running to that area. So what's unique about cranial nerve 8 is that it is two different structures. Cranial nerve 8 consists of the vestibular nerve that runs into the vestibule to control balance, right? It also contains of nerve that run to synapse in the ganglion called cochlea. Now, what the cochlear ganglion is responsible for is discerning sounds. So people with buzzing sound, people that have tinnitus, buzzing in their ears, as a result, a direct result of impact, may benefit from this. We know that tinnitus cannot be cured, but we have been able to show in a pilot study that reversal is possible. And we do the simplest form of SPG block. Another intervention is occipital neuralgia treatment, because especially for people that are engaged in rigorous activities, OMB can be very useful. So I recommend that for your practice as well. One upcoming procedure, popular procedure that's becoming popular recently is Botox, which is given every 3 months when a patient is qualified. And the reason why we administer the Botox into specific muscles every 3 months, not sooner, is to prevent the body from developing antibody against the botulinum toxin type A. There are many other treatments that we can use to combat headache, but these are just some of them, and they have been effective in controlling the symptoms of headache. Therefore, this is just an addition to what I'm saying when you have a team. Another intervention when it comes to concussion is to look at the effect, the severe effect of a coup injury to the C-spine. We have had scenarios of people with C1, C2, or C2 fracture that cause protracted headache. So sometimes you may want to just repeat X-ray in flexion and extension views. If there is neck symptoms, at times we have patients with spectacular spine. And the main intervention to that, if you don't want to go this surgical route immediately, that's if the patient is qualified, if there is no immediate life-threatening symptoms or signs, is to make sure that you improve the range of motion. We do that by doing interventions such as trigger point specific myofascial release, instantaneous myofascial relaxation, in order to enhance swift and up to par cervical range of motion. This does alleviate symptoms. This does arrest progression of degenerative changes that produce symptoms consistent with spectacular spine. So again, concussion is becoming more of a popular topic, and protracted recovery can be detrimental to the patient physically, emotionally, can affect many things, can affect sleep. But if you have a strategy, like a working strategy that I've just proposed, in order to facilitate neuroplasticity, you can have a better recovery. If anyone is interested in building a team like this, having a framework like this, please don't hesitate to reach out to me. My email address is oluseal@yahoo.com. Thanks for